Well, thank you so much for that kind introduction, and thanks for the CCSN for asking me to speak regarding goals of care in lung cancer. And I've changed the title here to Changing the Game for Lung Cancer Patients, because I really do think that we really have changed the game, and I think the future looks extremely bright for lung cancer patients. So here are my disclosures. I basically have three objectives today. The first, of course, is to outline the cancer problem and specifically the lung cancer incidence and survival that we have within Canada. And then I want to talk about the goals of care for lung cancer patients. That'll be a large proportion of my talk. And I want to highlight the critical studies that really have shown how we've truly shifted the paradigm and improved the lives of patients with lung cancer. So as many of you know, cancer is the leading cause of death in Canada. Sadly, it has outpaced heart disease as the #1 killer. 1 in 2 Canadians is expected to be diagnosed with cancer in their lifetime, and 1 in 4 will die from it. Now, when it comes to lung cancer, as many of you are aware, it has the highest incidence and sadly the highest projected mortality, with 1 in 11 men and 1 in 14 women developing lung cancer throughout their lifetime, and 1 in 14 men and 1 in 17 women will die from it. So we clearly have more work to do moving forward. Part of this is because, unfortunately, many patients who are diagnosed with lung cancer are diagnosed. You know, when I think about opportunities for change, I really do think that, you know, early detection is going to be critical. When we think about half the patients that we see in clinic already have stage 4 disease, thereby being incurable, I think this is a huge area of need. I think there is reason for optimism. I mean, we know based on statistics, the Canadian cancer statistics, this is from 2017, that we have made strides to decrease the cancer death rates. These are overall numbers. And then with respect to lung cancer, we have made strides both in males and females. There's a non-significant trend in females, but I suspect moving forward when we have more long-term data, we will start to see statistically significant and clinically meaningful improvements in the lung cancer mortality rates as well. You know, when we think about goals of care, I mean, everyone wants to be able to cure cancer, and that is our ultimate goal. I think one of the things that are as a first principle is, you know, prevention. I mean, if we can prevent cancer, that's certainly better than cure. And one of the things that I always talk to my patients about, even if they are diagnosed with lung cancer, is it is really important and their overall survival will be better even if they quit now. And so I think we need to do better with public health campaigns with respect to smoking cessation. We do know, though, that 15% of lung cancer will be in never smokers. And so we need to highlight the importance of smoking cessation while trying to minimize the concept of therapeutic nihilism about lung cancer. So it is a fine balance, but I do think it's about communication, and it's about really talking to your family and friends about the importance of smoking cessation. And really, it's about talking to our youth about preventing them from starting. Because if we prevent them from starting, we can thereby prevent them from getting addicted. I think the other thing that we're fully aware of is we should be looking at reducing exposure to secondhand smoke. Many areas of Canada, some actually have a high risk of radon, so having your home checked for radon, and then avoiding asbestos exposure. So these are important prevention measures. When we think about smoking cessation, I really like this graph because it tells us that smoking cessation really saved over 30,000 lives when you look from 1981 to 2012. And that's an extremely significant number. And it's something that we really need to focus on moving forward as well. So one of the other things that I think is extremely exciting, and it's been a long time coming, is the concept of screening. As you may know, we have screening programs for colon cancer as well as breast cancer, but we've been waiting around quite some time to actually have an implemented population-based strategy for lung cancer screening. We've had data actually that has been, was originally presented and published in 2011 with the National Lung Cancer Screening Trial showing a reduction in the risk of lung cancer death by 20%. And then more recently, we have a study called the Nelson study showing a 24% reduction in the risk of lung cancer death from low-dose CT screening. And so I really do think that moving forward, we need to look at implementing population-based strategies so that we don't get this thing called opportunistic screening, because it is only in this population-based screening programs where we truly see these reductions in risk of death from lung cancer. So I'd like to shift gears now and just to give you some background about, how we frame things in our minds as oncologists, and then how we kind of set out the goals of care. The very first thing that I touch on in my consultations is the concept of both the type of cancer that they have as well as the staging. Now, as many of you know, staging essentially means the extent of the spread of the cancer. So basically, stage 0 is cancer that has not actually developed into a cancer yet. It's considered carcinoma in situ disease, sometimes referred to as adenocarcinoma in situ. And these lesions can be removed and are cured by surgery. Then there is stage 1 and 2 disease, which is localized to the lung. Stage 2, of course, having local lymph nodes involved. And these are also curable with surgery. And often thereafter, where we see patients for consideration of insurance type treatments known as adjuvant therapies. Stage 3 is a bit of a mixed bag. Some of them undergo surgery first, but while many of them have lymph nodes that are enlarged in the middle of the chest, and these cannot be removed with upfront surgery and are better treated with chemo and radiation. And I'll touch on that and the new advancements when it comes to immunotherapy in this setting. And then finally, it's the stage 4 cancers, which, as I said before, unfortunately, about half of our patients actually present with stage 4. And inherent in this is that spread already to other areas, such as the liver or the brain or the bones, and this is deemed incurable. One of the things that I think is really exciting about lung cancer screening is this concept called stage shift. What I mean by that is if you look at the control group, meaning no screening, you're seeing 46% of patients diagnosed with stage 4 disease, thereby deemed incurable. However, with CT screening, what we're finding is that only 10% of these patients had stage 4 disease, and 60% of them had stage 1 disease. So this is quite optimistic. And I think this is one of the reasons why we do see a reduction in lung cancer mortality with CT screening. Now I want to shift to goals of care. And I think one of the most important things that patients, families, and oncologists all need to recognize is the patient is at the forefront. These goals of care are really defined based on patient values and preferences. Of course, stage of disease, as I alluded to before, must be taken into consideration. The patient's functional status, so how well you're feeling day to day, what you're able to do, what we refer to as your activities of daily living. And then of course, if your ability to do your instrumental activities of daily living, all of that needs to be taken into consideration. And the other thing is comorbidity. So what kind of medical problems that you may have, be it heart problems, kidney problems. I mean, these are really important when we're trying to pick safe therapies for our patients. So for me, when I think about goals of care discussions, I like to kind of look at things from the perspective of what they should not be. So, you know, the first thing to say is these should not just be a focus on code status or a discussion of what we call DNR, or do not resuscitate. That's certainly can be part of the entirety of the discussion, but is not the focus. The focus should not be on death and dying. It should not be delayed until there's a crisis situation. You should never feel pressured, uninformed, or, you know, think about it as a transactional or adversarial process. From my perspective, it's patient-centered, value-driven. It should start early in the diagnosis and focus on the entire trajectory of the illness. That is the treatments, the intensity of care, and by all means, advanced care planning. It needs to come from a place of exploration and be conversational and two-way, and then of course longitudinal. So I think foundationally, I think when I approach this, you know, I always ask the patients, you know, what the understanding is of their disease. As you can imagine, some patients when they come see me have already done quite a lot of research on their disease. They're familiar with treatments and even may know clinical trials that are available and open in their regions. And so it's important to have a starting point. And moving forward in the conversation, I'll then actually ask patients how much information they wish to hear. And that is really important before launching into, you know, information about diagnosis and prognosis and treatment. You know, we have many times patients feel that the control has been taken away from them. They've been diagnosed with a cancer that it's not their fault, and there's things that they have control over. And certainly the amount of information that I provide is well within their control. So I have some patients who want to know everything, and in fact, most patients do want me to be quite honest and upfront with them. However, I have others that just really want to know just the general management and moving forward. I think one of the things that I like to outline at the first visit, just to set expectations, is the concept of is it possible to cure? As I said to you, we always try our best to provide cure, but if the patient has stage 4 disease, then that tends to be an incurable situation. So we do have to have a thoughtful and honest discussion about that. Of course, quality of life is paramount, and then length of life as well. For a true informed discussion, you really do need to talk about the risks and benefits of each treatment strategy, and also the risks and benefits of foregoing treatment. And then, of course, talking about any clinical trials. And as I said, timely, honest, and empathetic conversations is really important for fostering trust, and that's critical for moving forward. So when we take a look at this from the perspective of different stages of disease, I thought it would be helpful to kind of review things based on stages. So stage 1 to 3 disease, as I alluded to before, the goal is potential cure. Now, of course, there are some patients who, based on their functional status or their life goals, may not want to aim for cure. They may say, okay, you know, I'm 85 years old and I've lived my life quite well, and I don't wish to receive any therapies that have side effects, or, you know, there's a variety of different reasons why patients may not wish to pursue radical or intensive treatments. So it is very patient driven, but there is a potential for a cure. So most patients in Canada actually receive treatment with surgery up front, and then they're seen by us as medical oncologists to discuss what we call adjuvant chemotherapy. Now, basically, the term adjuvant, what that means is, while the surgeon will remove everything that he or she can physically see, there may be small cells of cancer left behind that they wouldn't be able to see. And unfortunately, there's no tests that we can do with respect to blood tests or PET scans or anything like that that can pick up microscopic disease. So we do discuss, based on the stage, what the risk of the cancer coming back is, and then we talk about the risks and benefits of chemotherapy. I really do think that this is a huge area of need, because as it stands right now, all we have is chemotherapy, which only provides a 5% reduction or benefit in 5-year overall survival. So those numbers are pretty small, and the focus of the current research is to use immunotherapy, so use the body's own immune system to potentially eradicate the microscopic cancer cells. Now, we've looked at this after surgery, meaning adjuvantly. There's studies looking at it before surgery. That's referred to as neoadjuvantly. The premise behind this is several-fold. Number one, it actually will allow you to assess the sensitivity of the cancer to that specific therapy. It allows the cancer to shrink to help the surgeon remove it in its entirety, and potentially to decrease microscopic cells. So there are a number of adjuvant studies. We've participated in BR31, but this is just for example. There's several different immunotherapy agents that we're testing in this setting. And there are also a number of neoadjuvant studies as well that I've added to the slide deck, and by all means you can have copies of this after. For a full list of the clinical studies, you can look at clinicaltrials.gov.ca, or certainly ask your medical oncology team whether or not they have studies open in your area. Now, shifting to stage 3 disease, so stage 3 unresectable. So just to remind you, that's when you have a cancer in the lung that unfortunately has spread to the lymph nodes in the middle of the chest and is unable to be cut out up front. So with this situation, historically, what we've done is we've done 6 weeks of radiation. So a small amount of radiation every day, Monday to Friday with the weekends off, along with chemotherapy. So chemotherapy will improve the strength of the radiation, but also hopefully if there's any stray cells outside of that radiation field, they may be able to mop that up. One of the challenges is historically, only about 30 to 40% of patients actually received the concurrent chemoradiation. And I suspect that this will change, especially now that we have immunotherapy available after chemoradiation. I suspect the uptake more recently will be higher than this. The 5-year survival rate from chemo and radiation alone is 20%. So this is quite low, and this is a huge area of need. Thankfully, there was a large randomized phase 3 study that looked at using immunotherapy after you've completed your 6 weeks of chemoradiation. So after that, typically what we do is we do either some imaging, either a chest x-ray or a CT scan, to ensure that there's no progression of the disease. As long as there's stable disease or shrinkage of the disease, patients may go on to receive an immunotherapy called Durvalumab, which is given inside the vein once every 2 weeks for up to 1 year. And this has been shown to improve survival. So I wanted to just put a schematic here on how immunotherapy works. As you know, the immune system, the T cells will go around your body looking for foreign invaders, and that could be infections, but it also can be cancer cells. Now, cancer is tricky in that it has a protein on the outside of it. One of those proteins is called PDL1, programmed death ligand 1, and that protein actually tells the T cell that it's friendly. It shuts it off. It tells it not to attack it. So what we've done is there have been developments looking at little antibodies that actually block that interaction. They either block PDL1 on the cancer cell or PD1 on the immune cell, and thereby release the brakes on the immune system and allow it to attack the cancer. And we can see based on these large studies that it does indeed improve overall survival. And we have data for the 3-year survival rate, and you can see here that with Durvalumab, it is 57% compared with 43.5 in the placebo group. So this is quite dramatic. When you think about this, obviously we await the 5-year survival data over time, but recall that the 5-year overall survival rate is only 20%. So I suspect that this will be much higher than the 20%, and this is extremely exciting for our patients, and it really is a game changer. All patients who do not have a contraindication to immunotherapy certainly should be evaluated for 1 year of Durvalumab following chemoradiation. Now let's shift to stage 4 disease. And so stage 4 disease, as I had mentioned, historically has been felt to be an incurable situation where the goals of care have been quality of life and length of life. I really like to discuss with patients at the beginning of our consultation the importance of ensuring that there is palliative care involvement. I think there's a lot of preconceived notions about what palliative care means. What it does not mean is that it does not just mean end-of-life care. It is the entire continuum of care where we are providing supportive management to support us through the side effects from therapy as well as the symptoms of the disease. And I really like this bow tie model that was first introduced by Pippa Hawley, who is a palliative care physician here in Vancouver. Really, this concept is we want early palliative care, we want early pain and symptom management along the continuum over time. You know, I think part of this is if patients are eventually cured, then there's the survivorship rehabilitation piece. If unfortunately they end up progressing beyond all standard therapies, there is the important discussion of the hospice palliative care unit end of life and bereavement. So, you know, this should not be sequential. I think the take-home message here is that we really should be looking at this in parallel. It's not one or the other, it is both. And we have good data to support this. So there's this study that was published around a decade ago now looking at early palliative care for patients with metastatic or stage 4 non-small cell lung cancer. And basically what they did, they took half the patients and they provided them supportive care or palliative care early, and the other group had standard care. So in the red curve is the early palliative care. And basically these curves on the side here, you see the proportion of patients surviving. So at time 0, so when they're first diagnosed, 100% of them are surviving. And then over time, that curve will drop as patients pass away. You can see here the median, so median means the average. And so we're looking at the difference here of about 2.5 to 3 months extra life gained. The other thing, of course, it also provides a quality of life benefit. So I think, you know, there's definite evidence that early palliative care matters, and you know, you really should be seeing a palliative care physician, pain and symptom physician early on as well in your diagnosis. So one of the things that I think that we've struggled with in the lung cancer community is the concept of therapeutic nihilism. I think for many years, the proportion of money that was given to lung cancer research was a lot lower. And it still is lower than breast cancer and other types of cancers because of the concept of this therapeutic nihilism. I think we need to move forward, and we have a lot of reasons to be optimistic right now because there have been huge paradigm shifts resulting in dramatic improvements in survival, quality of life, and cure rates over the past decade in lung cancer. So I really like to provide a historical perspective. I think we can learn a lot about the past, and it also will make us appreciate where we are right now when we can look back and see what the survival rates were back in the early 2000s versus what they are right now. So just to give you some perspective, before 2010, advanced non-small cell lung cancer, the only tool in our toolbox was chemotherapy, sadly. And when you look at the survival was quite abysmal, with a median survival or an average survival of only 8 months. And this was a study looking at a variety of different chemotherapy agents, and none of them were any better than the other. And you can see here that many patients, there wasn't very many patients alive even at the 30-month mark. So the other thing is that only about 30% of patients in the past actually received therapy. And many reasons for this, of course. Some it was because several patients, of course, may have had problems when it comes to comorbidities whereby they were not candidates for chemotherapy. Some it was because of, patient choice, therapeutic nihilism, as I said, toxicity of treatments. So we actually looked at this here in BC, and when we looked, and so this was from 2009, and sadly in 2009 only half of the patients were actually referred to medical oncology, and only 30% of them went on to receive chemotherapy. So these are extremely low numbers. In Ontario, they looked at this as well, Dr. Satcher, and found that the first-line treatment uptake was only 24%, and the second line was actually only 8%. So clearly, low uptake. Certainly, with better treatment strategies and lower toxicity of treatments, this, anecdotally has improved and will continue to improve. So the big paradigm shift, the first huge shift, was actually in 2009. And in 2009, what was recognized was that there was a special mutation or a change in the cancer that was in particularly seen in female Asian never smokers. And when they went back and looked at those patients, they identified this EGFR mutation, and that refers to epidermal growth factor receptor. They had a pill form of therapy called gefitinib, where they found that there was a dramatic response rate at 71.2% in comparison with the chemotherapy where it was 47%. However, important to note, if you didn't have the mutation, you didn't derive benefit. So really important for us now to look at things not just from a histology or whether or not it's small cell lung cancer versus non-small cell lung cancer, but looking at things from a molecular perspective. What mutations are there in the tumor that we can potentially target and exploit? The data showed improvement in progression-free survival as well, and this really did change the paradigm of care for our patients. So shifting forward, we now, instead of looking at things from, as I said, a histology-based approach where we just look at the cells and we say, okay, these are adenocarcinoma, these are squamous cells or other. Those adenocarcinomas, we know that that's where we see these different molecular aberrations where we can use potentially use pills to target these mutations or rearrangements. EGFR is seen in about 15%. My population here in BC, I have a higher proportion of Asian patients here, and I would say that it's about closer to 20 to 25% here. ALK is seen in anywhere from 4 to 7%. We also have ROS1, which is present in 1 to 2%. We have a number of different alterations as well, including KRAS at 30%. So really important for us to identify these abnormalities. I like this schematic. It really just, shows how we've divided up advanced non-small cell lung cancer, where we have drugs that actually target the EGFR. We have many different drugs, including osimertinib. For the ALK rearranged cancers, we have pill forms of therapy as well, such as alectinib. ROS1, we have crizotinib. And BRAF positive, we do have agents that target BRAF. However, these unfortunately are not funded by provincial governments thus far. So when I look at the proportion of patients that may be able to receive a pill form of therapy, it's about 30% of lung adenocarcinomas. But for me, it's critical to obtain enough tissue so that we can assess these mutations and rearrangements. We know that targeted therapy does improve survival, and this is data now dating back to 2014 showing exactly that. The orange is targeted therapy. As I showed you before, survival probabilities along the side, and the line that's highest is best. So targeted therapy does significantly improve overall survival. Now, what is it like on the ground? What are we recommending here in Canada? So we do recommend assessment for EGFR, ALK, and ROS1, along with programmed death ligand 1 immunohistochemistry. So that's a protein that we look for on the outside of cells. There's a number of other agents that would be nice to know, and here in BC we're lucky because we have an onco panel that allows us to obtain access to have these various more rare mutations identified as well. So I thought I would provide a clinical vignette of one of my patients just to give you a sense of why identifying driver mutations matter. So this was a 37-year-old male Asian never smoker. He had dyspnea for 1 month and he had very severe hip pain. Pain was so bad actually that he was wheelchair bound. He came in to see me. His performance status was 3, meaning he was, in the chair or sitting or lying more than half of the day. The biopsy showed that there was a lung adenocarcinoma. At the time that I saw him, and this is sadly all too often do we not have the EGFR back when we see our patients. These actually we look for with proteins. So ALK, ROS1, and PDL1 will often have that back. I did have that back on him and they were all negative. I discussed that sadly, there needs to be a margin of safety for chemotherapy, and unfortunately he was too unwell for chemotherapy. But I was holding out hope that given his young age, never smoking status, and the fact that he was Asian, that we would have an EGFR mutation, and so I could give him a pill form of therapy. Just so for your reference, so this is basically a CT scan. So this is on the bottom, so he's lying on the couch, and it's basically looking from the feet upwards. This is the vertebral body, the spine here. And this is the heart. These are the airways right here, and this is the lung. So what you don't want to see is white. So this here is the cancer, as well as this area along here, some nodularity. Okay. The other thing that I did was a bone scan. So basically, on the bone scan, black is cancer. Now this is the bladder, so don't mind that. But this darkness right here and along here indicates that the cancer has sadly spread. When you look at the bones, so once again, he's lying on the couch, the CT imaging here, and usually what you like to see is a nice clean line like you do over here when it comes to the outer part of the bone called the cortex. What you're seeing here is that it's eaten away, and it's quite dramatically destroyed there on that. So not surprisingly, he was in a lot of pain. So thankfully, I get back the report a couple of days later that he has an EGFR mutation. So right away, I call him up and I let him know the good news, and I talk to him about the FLORA data, which is basically a 3rd generation EGFR pill called osimertinib. So it's a tyrosine kinase inhibitor, and it was compared to either erlotinib or gefitinib, which is a 1st generation EGFR tyrosine kinase inhibitor, and it showed there was an improvement in progression-free survival, and we also saw last year that there was an improvement in overall survival as well. So orange curve, osimertinib, blue is the comparator. There's clearly a difference here. You're looking at the 3-year rate of the overall survival rate, that's 10% more in the osimertinib arm. The other additional benefit to osimertinib is that it has the ability to penetrate this little envelope that's around the brain. So around your brain, you have this thing called the blood-brain barrier, and it's sometimes tricky for drugs to enter that. And so often we see patients actually what we call fail in the brain, meaning the first place that they may have progression of their disease is within the brain. But thankfully with the osimertinib, even if patients have low volume asymptomatic brain metastases, you can actually see response within the brain. So thankfully we have it Health Canada approved, and it's actually funded here in BC as of January of this year. So how does it work in practice? We know the studies, but how does it work in our patients? So I provided just an illustrative example here. So this is the before, and this is 3 months after osimertinib, and you can clearly see resolution of those white areas or of the cancer. And I think what's even more dramatic is the bone. So you're seeing here in the bone, you're actually seeing that the bone is healing itself. The cancer is being killed, and you're having the cortex, or the outside of the bone, is being reformed, which is quite dramatic. The patient quality of life, he actually is able to walk fully now. He doesn't need to take any morphine at all for his pain. He's feeling extremely well and tolerating this medication very well with no side effects. So the other big advancement is that of immunotherapy. So we know that immunotherapy can be given alone in the form of pembrolizumab. So this is an intravenous drug that's given once every 3 weeks in the patients that have a very strong, intense staining of the PDL1. Now that's programmed death ligand 1. Which is the protein that's expressed on the outside of the cancer cells. If they have a tumor proportion score of at least 50%, they can avail of immunotherapy. So they don't need to go with chemotherapy up front, which I think is a dramatic improvement. And certainly there's improvements in quality of life and overall survival in that study. And then in the setting of when the PDL1 is less than 50%, we have data now with a combination of chemotherapy plus immunotherapy in the form of pembrolizumab. So we've really transformed this whole paradigm of care for advanced non-small cell lung cancer. So when it comes to the PDL1 intense staining, so the one that's greater than 50%, and that's why it's important for us to have that data when we see you at first consultation so that we can really assess you for this. Important to note, if you have a PDL1 that's greater than 50%, but you have a positive EGFR mutation, we know that those patients do not derive as much benefit from the immunotherapy, and that the right decision in that instance would be to use a targeted therapy such as osimertinib in that population of patients. So just a point of clarification. Now, these were patients that were who we call wild type, meaning they didn't have an EGFR mutation or an ALK rearrangement. They did have this PDL1 greater than or equal to 50%. And this is longer term data. It's a 3-year overall survival. And you're seeing a 3-year overall survival rate of 44%. Now, this is unheard of. The longer term data, there's 5-year data for pembrolizumab as well, with the 5-year survival rates being in the range of about 1/3 of patients still being alive, which is dramatic when you compare that to historical controls where essentially you're looking at maybe 1% survival rate in that group. So huge improvements when it comes to survival as well as quality of life. So the quality of life has also been outlined, and they've done a really great job with evaluating that as a key secondary endpoint. And this also has been published showing that, you know, from a tolerability perspective, it's a no-brainer. And then from the quality of life perspective, there's improvements there as well. So just to remind you that in 2002, the average survival was only 8 months, and the 3-year survival rate was extremely low in the single digits. So really, we have the paradigm has shifted when it comes to the molecular alterations and the targets that we have that are very specific and precise and have better side effect profiles than chemotherapy. So about 30% of adenocarcinomas we can avoid upfront chemotherapy in. There's another 1/3 of patients that have a tumor proportion score of greater than 50, where we can also avoid upfront chemo in, and we can give immunotherapy alone in this population. And then, of course, there's the combination in patients who have a tumor proportion score of less than 50% with chemo and pembrolizumab. And the other thing to point out is immunotherapy has also shown improvements in survival with the atezolizumab in the extensive stage, or stage 4, if you will, small cell lung cancer. And then, as I mentioned to you before, the Durvalumab study, the Pacific study in stage 3 disease. So why is it that immunotherapy is so meaningful? So from my perspective, it's all about quality of life and safety, and I think we really have that data. The durability of responses is quite dramatic. If patients respond, they tend to respond for quite some time. And then, of course, the length of life is also really important for patients. And then the whole concept of tail of the curve. I'd mentioned to you 5-year survival rates in the range of 30%. The question is, are there going to be some of those patients that actually live out their natural life? For me, I always aim for that. I want to elevate that curve as high, the tail of that curve as high as we can, and have those patients live a long time. I think that's really something we should strive for. So I wanted to, just summarize here now and give us time for some questions. So just to kind of review, so lung cancer, as you know, remains the cancer with the highest incidence and mortality in Canada. That goals of care should be very patient-centric. It should be honest and empathetic, yet, we want to instill hope. I think that's really foundational. From a perspective of treatment strategies, we really do need to know the driver mutations of those molecular changes in the cancer. We also need to know the protein called PDL1, how high the expression of that is, so that we can better refine our treatments. I think, as I have exemplified in these slides today, that there have been dramatic advancements in the treatments that improve cure, quality of life, and length of life for our lung cancer patients. And it's a very exciting time to be treating lung cancer, and I'm very optimistic about the future. So I will stop there and I will open it up for questions. Thanks for your time.
Thank you, Dr. Noonan. We can now move over to the Q&A component of today's presentation. A reminder that we do have a few excellent questions that have been submitted, but if anyone else cares to submit any, you still do have a few minutes to do so. So the first question we have is, what evidence is available to indicate the cause of lung cancers? Could it be viral, bacterial? Could it be genetic? Could it be linked to chemical exposure?
Yeah, I think that, epidemiology is always challenging, because what happens is that when you look back to look at potential associated factors, there's a lot of things that we refer to as confounding variables, meaning other exposures. And so it's really tough to tease out, is it exactly this chemical that we're dealing with? We know, based on studying large number of patients who have smoked, when you go back to look at those populations, there's a lot of mutations within those cancers. So we know that there is a huge smoking association. And as I said to you, about 85% of all lung cancers are associated with smoking. But there is an inheritability. And so the challenge, of course, is while we have known genetic alterations such as BRCA1 and 2, which increase risk of breast and ovarian cancer, we don't have a specific lung cancer gene that we can test patients. So when I'm doing my family history and I see in patients' family histories that they have other people in their family that have had lung cancer, irrespective of if they've smoked or not, I suspect that there is an inheritability or a genetic association as well. So I think those are the sort of the top two. I think it's really going to be tough to kind of tease out, is it something that we're eating or these other things? We know asbestos, we certainly know that increases the risk of mesothelioma, which is a different type of lung cancer. It also can increase the risk of non-small cell lung cancer as well. So it is inherently a carcinogen. We know that as well. We know that radon, there's data for radon as well. And so there are things that are more associated, and there's sort of a causal link, but there are other things that we postulate maybe, but it's really tough to hammer out because, as I said, there are so many different variables when you look back at this population, and it wouldn't be ethical to randomize patients to, you know, to a potential carcinogen versus not and prospectively follow. And that's the reason why we epidemiologically we look back to try to look for associations. But yeah, that's a great question.
So our next question is, if a patient is living in another Canadian province that does not provide these treatments, how difficult is it for patients to receive treatments in BC?
Yeah, I think that, you know, that is one of the things that is quite challenging. I think for me, you know, ethically, I always, you know, you want to provide uniformity of care across the country. One of the things that I think that, you know, is always a struggle is what happens often is we present the data at large meetings showing improvements in survival. And then what needs to happen from a safety perspective is it needs to be submitted to Health Canada. For Health Canada is our regulatory agency, which has to review all the data to ensure that it's effective and safe. And then it will, what we call, get a Health Canada indication. And once it gets a Health Canada indication, in Canada, we are a health technology assessment nation. And what that means is that we actually have a separate body that looks at the benefits, it looks at the risks, and it also does look at the cost. And we have this concept called cost effectiveness ratio, so incremental cost effectiveness ratios. And it's an organization that's called CADIF, which is you know, can make a recommendation to for provinces to fund or not fund. So there's always these delays between Health Canada approval and then ultimate funding by provinces. And there will inherently be some provinces that obtain drug earlier than others. I feel like, you know, this is an instance where I really do think that the pharmaceutical companies have stepped up, and they often do provide access programs to bridge patients to allow them to have access to these drugs until we can get access and funding provincially. So that's one of the things that I think that, you know, patients, of course, as advocating for themselves, you know, certainly need to be aware. I mean, if it has an indication, then it's like, how do you get the drug? But access programs is something you should always ask about, because there may indeed be access programs, be it co-pay, meaning 20% pay if your insurance company will pay the 80%, or if you don't have insurance, they'll often pay, potentially pay for all of it. So that has been really important for my patients. So that I can get access to drugs until they're provincially funded. Yeah, it's not an easy situation. I totally agree. I do think we need to do better.
The following question is, can you talk about the role of T790M, acquired mutation, in the use of forgive my pronunciation, osimertinib?
Yeah, exactly. So many patients, so some patients, for instance, that I've treated, I started to treat like 3 or 4 years ago, or even a year ago before I had access to first-line osimertinib. Those patients were started on drugs such as gefitinib or second-generation EGFR tyrosine kinase inhibitors such as afatinib. Now, we know with those patients, if they start to progress, about 50% of them will have an alteration in their cancer that's basically a resistance mutation to that drug. We know that cancers are what we call genomically unstable. They're smart. They know how to alter themselves. And one of the ways that they do that is they actually have a mutation in 790 position, so T790M, which is a specific mutation that confers resistance to afatinib and gefitinib, but it's a situation where we know, and we have level 1 evidence. There's a study called the AURA3 study showing that osimertinib actually has high response rates and a long progression-free survival in that setting. The trick here is to ensure that you test and that you don't miss a window of opportunity. So what I do is, you know, there's 2 ways. So the gold standard is to do a biopsy. But as you know, biopsies in lung cancer can be problematic. It can be tough to get enough tissue, especially if it's just in the lung. So the other way that we can sometimes do it is actually send plasma testing for cell-free DNA, and we look for the circulating DNA inside the blood, and we will do assessment on that to see if we can capture the T790M mutation. So that's another way to try to get around it. So we have a couple of ways to do that, but at the end of the day, you're looking at a rate of uptake of 50%. So when I think about sequencing, I think about using my best drug first, because we know there will be attrition. You may recall from the Adrian Satcher data that I presented earlier, 24% of patients had first line, but then only 8% had second line. So there will be this, what we call natural attrition of patients that actually will die before they get to second line. So that's why I like to use osimertinib in the first line setting. And then I don't need to potentially worry about rebiopsying upon progression and trying to find this T790. But certainly with the patients that I have on afatinib right now or gefitinib, upon progression, I will indeed be looking for that special mutation, that T790M mutation. That was a great question.
Just got another question that came in. Do you have patients currently on larotrectinib?
So that is, so larotrectinib is a drug that actually targets NTRK fusions. Now we know in lung cancer that NTRK fusions, it is a bit of a needle in a haystack phenomenon. However, if you do find one, they do have dramatic responses. It also has CNS penetration. So, you know, it's one of these things where if you don't look for it, you won't find it. And the problem with a lot of these panels that we have available across the country is many of them do not have an effective way to look for fusions, meaning part of one gene fuses with part of another gene. And that's a situation where often you may need other types of testing. Now, sometimes that's available through a company access program. Other times, unfortunately, patients may have to pay out of pocket, such as Foundation One, which can cost in excess of $5,000. So that can be quite challenging and expensive to do, but it's something where it's one thing that we need to start looking for as well. And we're chopping up that pie into smaller and smaller pieces, but I think at the end of the day, it's just really great for patients, because anytime I can avoid chemotherapy and provide an effective, well-tolerated drug, I really will do my best to try to obtain access to that. But the short answer is, unfortunately, I haven't found it yet. So I don't have anyone on larotrectinib yet, but I continue to search for NTRK fusions.
I think we have time for 2 or 3 more questions. Is HPV, or can HPV be linked to lung cancer?
You know, that's so interesting. I think, you know, the more understanding we have of cancers, the more we realize that this, you know, that viruses can certainly cause many different types of cancer. Historically, when you look at HPV, they tend to be more associated with what we call squamous cell cancers. So, for instance, squamous cell cancers of the vulva, of the anus, of the cervix, and of the head and neck. So it tends to be more like linings. However, as you may know, you know, there's a proportion of patients that have squamous cell cancers of the lung. So it's something where, you know, it's not definitive right now, but I do think we need to do more research to really define, you know, that population. In general, we think that squamous cells of the lung are highly associated with smoking. However, I do have patients that are squamous cell of the lung and they've never smoked. And I always wonder whether or not there is another carcinogen that may have been implicated in that instance. Yeah, no, that's a wonderful question. I think we really need to do more research into that.
And our next question is there anything I can do to help manage the side effects of my treatment?
Yeah, I think one of the big challenges, of course, is ensuring that you have good quality supportive care. And I alluded to this concept of sort of the bow tie concept of management. And so I like my palliative care team and my pain and symptom team to meet my patients with lung cancer early, to develop rapport and to follow them along their cancer journey, because once again, they can help with the side effects from the or the symptoms from the cancer, but also can be sometimes helpful when it comes to managing the side effects as well. Now, of course, it depends on the specific side effect that you are having. I think one of the more challenging ones to treat is that of fatigue. And so that can be quite problematic. When I see the advancements, for instance, when I see first line EGFR tyrosine kinase inhibitors, second line, and then third line, when you think about that, we're actually improving things not only from an effectiveness point of view, but also making drugs that are better tolerated. As I said, my main goal is to try to identify driver mutations or PDL1 greater than 50 so that I can potentially avoid chemotherapy. Nonetheless, we sometimes need to bite the bullet and give chemotherapy. Chemotherapy associated fatigue, there's been many studies looking at different stimulants and those kind of things. And unfortunately, it hasn't really been proven to be beneficial. One of the things that seems sort of counterintuitive, but exercise actually does help. As you know, exercise can release endorphins, and it has been shown to improve cancer-related fatigue and therapy-related fatigue. So that's something that I try to encourage my patients to do.
We do have one final question that's been submitted. Do you know anything about the recently identified NGR1 fusion and possible treatments?
Yeah, from that perspective, I actually don't have data on the top of my head. I think one of the things for me is when you identify a mutation like that is really looking for what we call phase 1 studies, which are first in human studies. And these studies are highly variable across the country. So you may need to do a little bit more research in your region to figure out whether or not there's actually a drug that specifically targets that. And it does take some time, but I think it's worth the effort. Right now at my center, we don't have anything open for that specific aberration. Yeah.
Okay, well, thank you everyone for submitting your questions. That brings us to, or today's session to an end. If anyone does have further questions post-webinar, please feel free to direct them to partnerships@survivornet.ca, and I'll be more than happy to pass them along to Dr. Noonan. We also, our CCSN would like to thank you for attending today's webinar, but we'd also like to take this opportunity to thank AstraZeneca for sponsoring today's webinar, and we definitely appreciate Dr. Noonan for presenting today. We'd just like to remind that this webinar will be available in full tomorrow on CCSN's YouTube and SlideShare accounts. And everyone who took the time to register for today's webinar will receive an email containing links to to today's webinar. Our next webinar, titled Exercise in Cancer, is scheduled on March 12th at 1 p.m. Eastern Time. To register for any of CCSN's upcoming webinars, please visit our website on survivornet.ca. And that concludes today's session. Thanks again for everyone for taking the time to join us today, and we hope that you enjoy the rest of your day.